بسم الله الرحمن الرحيم الحمد لله رب العالمين صلى الله وسلم وبارك على نبينا محمد. Welcome back to our sessions with the pathophysiology of congenital heart disease. We have done the cyanotic congenital heart disease, acyanotic congenital heart disease, obstructive right-sided congenital heart disease. Today we'll be talking about pathophysiology of left-sided obstructive congenital heart disease lesions. And inshallah, in the next couple of sessions, we'll talk also about regurgitant lesions and possibly about some of the acquired heart diseases pathophysiology. So what are the left-sided structures that can be obstructed in the human heart? We can start from within the lung, which is the pulmonary veins, up to their connection with the left atrium. So these are the two right veins, these are the two left veins, upper veins, lower veins, 1, 2, 3, 4. Anywhere in the course of the vein, a stenosis can happen, whether it's at the junction with the left atrium or just before or deep in the lung. The severity of such disease is different, but obviously when we have involvement of the intraparenchymal pulmonary veins with the stenosis, including all its length up to the entrance to the left atrium, then this is a very severe form of pulmonary vein stenosis. This is just to show you or to tell you where the obstruction can be. It can be just within the lung, somewhere between the entrance and the lung, or at the entrance. Anyhow, it will cause hindrance or prevention of the pulmonary venous blood flow from going into the left atrium. Before we go into the deep pathophysiology of such disease, we can say that it does not mean when we have pulmonary vein stenosis that all the veins should be involved. It could be one vein, two veins, one side, other side is okay, or all of them are actually stenotic. Whenever we have a single pulmonary vein involved, usually that does not produce significant pathophysiology. That means the physiology, the normal physiology of return of the pulmonary venous blood flow from the lung will just continue in its usual way and will not have a pathophysiological effect. So let's take one vein. Let's say this is the left lower vein, which is actually commonly involved and being a single vein stenosis. If this vein has a stenosis, then the left lower lobe of the lung, the left lower lobe of the lung, this is the left pulmonary artery, this is the upper lobe, and this is the lower lobe artery. This lobe here, which is actually the larger lobe, and this is the upper lobe. This lobe here, its vein, when it's coming back, if it becomes stenotic, okay, and let's say it's just hypoplastic, it's stenotic throughout its course. You see? It's almost obliterated. This lower lobe will be congested. The venous pulmonary blood flow will not be able to empty into the left atrium. So the left lower lobe will be congested, full of interstitial fluid because of capillary or venular intravascular fluid leaking into the extravascular compartment, causing interstitial edema or pulmonary venous edema in that lobe. Nothing much will happen in terms of pulmonary pressure, in terms of right ventricular pressure, in terms of amount of blood going enough to the left atrium, to the left ventricle, and giving enough cardiac output. It is just part of the lung, so it usually will not cause a major issue. In the lung itself, it does, because we might end up having that this lobe becomes dysfunctional in terms of what? In terms of oxygenation of blood and in terms of ventilation and removal of CO2. And usually what happens first is, because of the pulmonary edema, we lose the ability to get rid of the CO2, and we can end up that this lobe actually becomes completely dysfunctional. Being a left lower lobe, it's an important lobe. It compromises about 2/3 of the left lung. So we might have symptoms, some respiratory distress, some physical ability decrease, not that complete free of symptoms in the patient, but the pathophysiology will be very limited to only this lobe, causing changes in this lobe. Obviously, this is not great. It depends if these changes are severe enough. Something has to be done to relieve this obstruction. If it is only a mild or a moderate, then the rule applies that one vein stenosis will not need therapy because it does not cause significant pathophysiology. In the very rare occasion, if this is severe enough and it is involving the left lower lobe or a right lower lobe, which is also a big lobe, it very rarely may cause reflex pulmonary arteriolar vasoconstriction in the other lung, and probably in the upper lobe, the normal lobe of the left lung, and then it will cause some degree of pulmonary hypertension, usually mild. I don't think it will ever exceed moderate, but then we do have a pathophysiological effect, although, as I said, this is quite rare. And most of the time, the left lower lobe will find venous channel collaterals that can join the right upper pulmonary vein and enter into the left atrium, so decompressing the left lower lobe. And that's why we usually do not have, when we only have one vein stenosis, we do not have much of pathophysiological effect. From this, I'll move to, what if we have two veins? It depends if these two veins are actually on the same side or on one on each side. Obviously, if we have two pulmonary vein stenosis on the same side, let's say it's the right or the left, then that whole lung will be obstructed. The pulmonary venous return from that lung will be obstructed. At this stage, just to finish up with the simple part, let's say it's one vein on the left and one vein on the right. Again, because it is one here and one there, probably not much pathophysiological effect will happen other than what I have just described, the congestion of the lobe that the vein drains, and in the rare occasion, a mild to maybe moderate pulmonary hypertension, not leading to much more than that, and usually collateralizing with other veins to be able to empty. That finishes the issue of one vein, whether it's unilateral or bilateral. Now let's talk about the real stuff, which, let's say we have unilateral, right-sided, all vein stenosis. The two veins are stenotic. So the right lung, this is the right pulmonary artery. with an upper lobe branch, a middle lobe branch, and a lower lobe branch. Sorry for the drawing. Just take it away. Because I drew them not so proportional to their sizes. Usually the upper lobe is smaller, the middle lobe slightly larger, and the lower lobe is the largest part. So if this lung, the right lung, is obstructed, its venous return, which are these two veins, if let's say this is now the left atrium, the veins are coming from within, they form into the vein, and the other vein. If these veins are stenotic, these right-sided, without the SVC obviously, if these right-sided pulmonary veins are stenotic, whether at lumen or at orifice or total length, if these veins are stenotic, then we have to talk about, are they mildly stenotic? Are they moderately stenotic? Are they severely stenotic? When we say, are they mildly stenotic, we mean that there is probably a pressure difference the left atrium. If we say that they are only mildly stenotic, then the pressure difference between the left atrial pressure and the venous pressure, the intraparenchymal venous pressure, is probably less than or equal 5 millimeter mercury. Mild pulmonary vein stenosis, pressure gradient less than or equal 5 millimeter mercury. In such a stage, we know that the left atrial pressure, normal left atrial pressure, is anything between 4 to 8 millimeter mercury. So let's assume a 5 and assume the highest number, then the pressure here will be 13 millimeter mercury. What's a normal pressure in the pulmonary artery? We've said before that the systolic pressure of a normal artery can be up to 25 millimeter, or less than actually 25 millimeter mercury. Still, the pressure here, the back pressure, is much lower than the pulmonary artery pressure. Usually the diastolic will be 10, and then the mean will be around, the mean pressure here will be around 15 to 18 millimeter mercury. This 15 to 18 millimeter mercury is higher than this 13 millimeter mercury, so obviously the flow can continue with probably mild or no elevation in the mean pulmonary artery pressure. And in such condition, that would be probably the only pathophysiological effect. A mild rise in the mean pulmonary artery pressure. Blood can still go in mild pulmonary stenosis even if it's full unilateral, that means the two veins, and the lungs will be mildly congested. No symptoms should be expected except maybe on severe exercise. We do not expect true pulmonary venous edema in this lung. So, and that would apply obviously even to the left side if it is unilateral. What if we have bilateral mild pulmonary vein stenosis? Again, we probably would not expect much pathophysiological effect other than mild dilatation and enlargement of the pulmonary veins, whether intra-parenchymal or outside the lung, mild or very little extravasation of pulmonary venous fluid into the extra vascular compartment, and maybe mild pulmonary edema, and again a mild, not more than mild, elevation of the pulmonary artery pressure, which the RV, the right ventricle, can handle very well. I mean, we said that this is the pulmonary artery. Where is it connecting? This is the left. It's connecting obviously through the pulmonary vein, to the pulmonary valve, sorry, to exactly the right ventricle. Then this pulmonary artery, which is supposed to be here, like that, will reflect that mild elevation of pressure because of the mild stenosis, whether unilateral or bilateral, on the right ventricle. This will not cause anything to the right ventricle. Not much hypertrophy, not much dilatation, function should not be affected, cardiac output should be maintained, no venous congestion on the right side because of such stenosis. You can notice in what I have said that though this is a left-sided obstruction, but its effect truly, because it's before entering the heart, it's before entering actually specifically the left ventricle, its effect is almost on the lungs and the right side. This is mild pulmonary vein stenosis, gradient less than or equal 5 millimeter mercury, whether unilateral or bilateral. The effect is mild elevation of the pulmonary veins within the lung, intraparenchymal, and a possible mild elevation of the mean pulmonary arteriolar pressure because of this mild venous congestion and elevation of the pressure in the lung. From this, I will move on to talk about moderate pulmonary venous obstruction, and then it's a totally different story. Although mild to moderate or moderate pulmonary vein obstruction, stenosis, does not require interference from us, I mean surgically or interventionally, because still the cardiac output can be maintained, still the right ventricle pressure and function and cardiac and output will not be significantly affected, still the lungs will not be severely congested with extravascular pulmonary interstitial venous edema, and so on. It will be just a pathophysiological effect. And what do we call moderate pulmonary vein stenosis? How do we grade it? If the mean gradient, the pressure difference between the area after the obstruction and the area above the obstruction, that means the veins within the lung, and where the stenosis ends, let's say it ends at the left atrial entrance or orifice, then it's the difference between the left atrium and the area above, measured by Doppler or measured in the cath lab by direct pressure measurement. We talk about a mean of above 5 millimeter mercury, but less than 10 millimeter mercury. Or let's say, just to make it easy, less than 12 millimeter mercury. So a 5 to 12 in that range will be considered moderate. And here we are talking no more about single vein stenosis. We're talking either about a unilateral, 2 veins, or all the veins are involved in the stenosis in a moderate fashion. It means if I put my Doppler by echocardiography, or if I put my catheter and measure, I will find that the pressure difference between the low area, which is the receiving part, which is the left atrium, and the area above the obstruction is more than 5 millimeter mercury, but less than 12 millimeter mercury. Let's apply the same that we talked about before. If, let's say, just for simplicity, this is now, we talked about the right lung, let's talk now about the left lung. This is the left pulmonary artery, left upper branch, left lower, the left lung, and these are the left veins coming out. Okay, just for simplicity of drawing, it is not absolutely accurate, but I'm going to try to make it a touch more accurate. Something like that. Okay, so if these veins are involved in a moderate fashion, let's say the obstruction is where it enters the left atrium, then if we know that the normal pressure within these veins is now elevated above the normal by at least 5 to 12, we said before that the left atrial mean pressure is normal between 4 to 8 millimeter mercury. Let's take now the 8 plus the maximum, which is 12, less than 12, let's say 11. So 19 millimeter mercury will be the pressure within the intraparenchymal pulmonary vein. It will be here 19 millimeter mercury. If you remember, we just said before that the normal mean here is anything between probably 13 up to 18 maximum millimeter mercury. This is the mean PA arteriolar or artery pressure. If now this is 19 and this is supposed to be normally 13 to 18, no blood can pass. The pressure is just not enough to push the blood. Obviously, this pressure will never remain now 13. Let's add the normal here would be around what? Let's say 8, so we have 11 difference. We will add that 11 difference to the lower mean, 13. Now, because of this moderate pulmonary venous stenosis, our mean pulmonary arteriolar pressure will be at least 24, 11 plus 13, and it can be up to 30 millimeter mercury. You can see here now we are reaching pulmonary hypertension by definition. For sure that this pulmonary artery now is hypertensive. Fortunate enough, even if it was 30 mean pulmonary artery pressure, the right ventricular pressure, let's say it has an end diastolic pressure of normal 6, let's say just 8, just for pushing it to the maximum, then the RV pressure here will be around 38 or 40 millimeter mercury. This pressure is still low enough for the right ventricle to be able to function near normal with not much hypertrophy, maybe slight hypertrophy, but not much hypertrophy, not much dilatation, no decrease in cardiac output, no backward venous congestion in the right atrium and in SVC and the IVC, no significant tricuspid valve regurg or pulmonary valve regurg because of the high pressure, because it's still a moderately elevated mean pressure. It is not a severely elevated mean pressure. Let me take back, this is the mean. Probably the systolic here will be around 50. I'm sorry, it's not 38. It'll be around 50. Again, a pressure that the right ventricle can take quite well, although it's reaching the limit where the right ventricle may start showing some changes. Obviously, if it's moderate and left for a very long time, the effect might be seen more on the right ventricle, showing some hypertrophy and maybe some tricuspid regurg, but the cardiac output will be maintained. The venous congestion on the systemic veins will not happen, but definitely we will have pulmonary venous congestion in the whole lung that's there, and it will give symptoms of dyspnea on exertion, probably on moderate exertion, and it should not give any hypoxemia, it should not give any hypercapnia, no change in acid-base balance, because again, the cardiac output through the lung and to the heart and from the heart to the body will be maintained. And that's why even in moderate pulmonary vein stenosis, we probably do not need to intervene surgically or interventionally. We may need to use some medications to relieve the pulmonary venous edema. Not much medications really to relieve the stenosis, but probably diuretics, just relieving the preload, because now the preload in the lung is increased because of the obstruction, because the lung is not being able to empty properly in the left atrium, and hence we will have pulmonary venous edema. Any other pathophysiology that can be expected with such pulmonary vein stenosis, moderate? What happens to the cardiac output and the left atrium and the left ventricle? In most of the cases, nothing will happen. The left atrium size will be almost normal. The left ventricle size will be almost normal. The cardiac output to the left side should be normal, because yes, there is a stenosis, but the pulmonary artery will elevate its pressure and will be able to push the blood to the pulmonary arteries through the veins and get to the left side. With exercise, with severe exercise, moderate to severe exercise, with extra demand, this may give more symptoms or become more significant. So I hope I've explained this part. And finally, we will go for the pulmonary veins to severe pulmonary venous stenosis. And here, and when we say severe pulmonary vein stenosis, whether it is unilateral or bilateral, it will affect the right ventricle and it will affect the the pulmonary pressure and can affect the patient quite significantly. So, severe pulmonary vein stenosis, mean or pressure gradient between the left atrium and the proximal part of the vein will be more than or equal to 12 millimeter mercury. Usually talking about 15 to 18 millimeter mercury. So this is quite a severe obstruction. Again, why? Let's take it from numbers point of view. The left atrial pressure, we said the mean is 4 to 8. Let's say, just for simplicity, it is 8 mean pressure in the left atrium. If we take a middle number, that the gradient across the obstructed veins is 15 millimeter mercury. So 8 plus 15, that's 23. Let's go back to our lung. If this is now the right lung, right pulmonary artery, upper lobe, middle lobe, and lower lobe. Okay, if, I guess my hand drawing is deteriorating sometimes, so sorry for that. Let me just put it back in a better drawing. That's better. This is the right pulmonary artery. So if this pressure is mean of 8 and we have now a stenosis mean of 15, 8 plus 15 is 23, so this is the right lung. So the intraparenchymal venous pressure now is 23 millimeter mercury. Okay, let's just make it. It is now 23 millimeter mercury in the venous side. We said that the mean pulmonary artery pressure is anything between 12 to 18 millimeter mercury as normal. If we now take 18 plus 23, that's already a mean of 41. So now we will have severe elevation of the pulmonary artery pressure. If the mean here becomes 41 millimeter mercury, if this is the mean, and we assume a difference between the mean of around 20 to 30, if we just take a 20, then the systolic PA pressure in such situation will equal 20 plus 41, that's 61 millimeter mercury. That will give us, if we add the 8 end-diastolic pressure of the right ventricle, then the right ventricle pressure now, just for simplicity, add 9. 61 plus 9, now it is 70. This is severe elevation of right ventricular pressure. Right pulmonary artery pressure now is severely affected, severely elevated. Right ventricular pressure now is severely elevated because it is severe pulmonary vein stenosis. Here, we expect the back effect of such stenosis on the lungs, causing severe, significant pulmonary venous edema. Even if it was unilateral, the other side will have reflex pulmonary venous congestion and will add to the pulmonary hypertension. But if it was unilateral, The only difference will be, although the pressure will be equal in the two lungs, equally elevated, very high, the only difference, if it is unilateral, the lung that has its veins obstructed will be congested and will have pulmonary vein obstruction. If it was bilateral, then both lungs will look hazy and with a glass ground glass appearance of pulmonary interstitial edema on both sides. So now we have significant pulmonary venous pressure elevation leading to extravasation of the intravascular fluid to the vascular compartment, causing significant pulmonary edema, number one, and with all its pathophysiological findings and complications, by the way, we can end up, we will end up, by the grace of Allah, that the PA pressure will be elevated and the right ventricular pressure will be elevated severely. Pulmonary artery pressure, severe elevation, can have pathophysiological effect on the lung itself. Usually with obstructive left-sided lesions, these pathophysiological effects on the pulmonary arteriolar bed are quite delayed, and most of the time they are actually reversible. It's not like primary pulmonary hypertension, where the acceleration of vascular injury and vasculopathy and the diminution of the pulmonary vascular bed, arterial vascular bed, is more. In obstructive lesion, though it causes, like in severe pulmonary stenosis, severe elevation of the pulmonary artery pressure, these arteriolar changes from intimal injury to thrombosis to fibrosis to complete obliteration, irreversible, all these stages are quite delayed, but if left for a long time, they can happen. And relieving the stenosis after that long time may still leave the patient with significant pulmonary hypertension with all its pathophysiological and clinical effect. So this is the part for we talked about the veins, the pressure and its effect in the pulmonary artery side. What about the elevation of the pressure in the main pulmonary artery? Obviously, there will be pulmonary valve regurgitation as a pathophysiological effect. Usually, this regurgitation does not add much to the pathophysiological importance of chest disease because it's usually mild, maximally moderate, and that would not add any volume load, any significant volume load to the right ventricle. The problem here will be major pressure load on the right ventricle, not because of obstruction of the right side, but obstruction of the left side, leading to reflex pulmonary hypertension and right ventricular hypertension, with all its effect of significant right ventricular hypertrophy. So let's write it. It will have significant right ventricular hypertrophy. May cause, if untreated for a long time, may cause significant decrease in RV systolic function. And if we just continue up, it will give us tricuspid valve regurgitation, and that can vary from mild to moderate to severe depending on the RV function and the severity of the severe pulmonary hypertension, and depending on how much right ventricular dilatation and failure happens because of the severe elevation of the pulmonary artery pressure because of the severe pulmonary stenosis. So tricuspid regurg can be mild, moderate, severe. Mild to moderate may not cause much addition to the pathophysiological effect of severe pulmonary stenosis, but obviously moderate to severe and severe will cause deleterious effect on the right ventricle, causing more dilatation of the right atrium and enlargement, congestion of the pulmonary venous return with all the effect that we have spoken about before in severe obstruction of the right side. Here is almost similar. It's not an obstruction, it's just an elevation of the pressure. So at this stage, we should expect all right ventricular hypertrophy, we talked about, right ventricular systolic function being affected, right ventricular diastolic function also being affected, because the right ventricular and diastolic pressure will also elevate significantly because of the elevation of the systolic pressure and the significant right ventricular hypertrophy, possible dilatation and possible decreased systolic function, plus maybe added to by the significance of the tricuspid valve regurgitation. So we just move up. We know in such situation the cardiac output may not be maintained quite well, and it can be actually a significant emergency if this is happening very early in life and more on a fast or an acute way. If it's more chronic, then it's more tolerable. If it is not, no, then it becomes like a real emergency, and the patient may have significant bilateral pulmonary edema plus minus the right-sided ventricular failure with all its complications. So cardiac output can be limited in this situation. Right side cardiac output and left side cardiac output. Not much blood will be coming into the left atrium because of this severe stenosis, unless there is an ASD somewhere where this right-sided congested blood can escape into the left side and maintain the cardiac output on the expense of the patient becoming significantly cyanotic. These patients with severe pulmonary stenosis, they will not look cyanotic because most of them do not have the ASD. They will actually look dusky, grayish color, typical presentation of somebody with low cardiac output state, and obviously they have severe or significant respiratory distress, hypoxemia, hypercapnia because of the significant pulmonary edema. Another pathophysiological effect can happen is that their left atrium may be much smaller because it hasn't received much volume. Their left ventricle may be also smaller because it did not receive significant cardiac output or flow to grow and take its normal size. Other left-sided obstructive lesions like aortic stenosis, coarctation of the aorta may also happen with these lesions, not necessarily because of the flow theory, the decreased flow theory, but in part, it is because of this theory. So in such patient with severe pulmonary vein stenosis, we have major pathophysiological effect. I will end up the last pathophysiological effect, which can happen because of the right ventricular significant dilatation and dysfunction, the right atrial significant dilatation and dysfunction. Arrhythmias can be expected, mostly atrial, but it can be ventricular arrhythmia, can be significant. One more pathophysiological effect, if it is left because of the severe elevation of the pulmonary artery pressure and the venous obstruction, pulmonary hemorrhage can happen. So, and this is really the end stage part of the pathophysiology. I hope I've explained pulmonary venous stenosis in a good way, in an easy way to understand, but we always have to think with obstruction, What is the gradients? What is the pressure difference? How much does that affect in a change or in an increase the normal pressure? And how much is that compared to mild to moderate to severe? And when it's severe, what are the effects? The effects are usually, are they on the lung? Are they on the atria? Are they on the ventricle? Are they on the cardiac output? Are they on the venous return, systemic? Are they on the pulmonary vein, systemic? If we always think in this kind of a comprehensive way, whatever lesion I may give you, you will actually be able to figure out the pathophysiology if you follow a very logical thinking in such patients. Thank you. Assalamu alaikum. Welcome back. So we spoke about pulmonary vein stenosis, mild, moderate, severe, unilateral, bilateral, pathophysiological effect. Now we will take it to the next level. If the obstruction is not in the pulmonary veins, where can it be in the heart? These are the two ventricles, two atria. Mind my drawing. Superior vena cava, inferior vena cava. We talked about the pulmonary veins. Mitral valve, tricuspid, interventricular septum, left ventricle wall, right ventricle wall. طيب. So if the obstruction was not in the pulmonary veins, which we just described, if it's not there anymore, where can it be? It can be anywhere, the next, between the mitral valve and the cavity of the left atrium. There is something called cor triatriatum, which is what? Basically, the pulmonary veins are coming here, and there is a membrane that is grown into the upper third of the left atrium cavity with what is just a small hole left in it for all the pulmonary blood flow coming from the veins to go through. Obviously, this is an area of obstruction. Although the veins are normal, although their attachments is normal, yet they're emptying to what you would call a confluence. You can say it's a confluence, or to an area, or to a lake-like space that empties only through one hole, one defect to the rest of the left atrium. Obviously, if we have 4 veins coming in and emptying only through one defect or one hole, in cor, let's say in here, in cor triatriatum, this is our second obstructive lesion on the left side. If this area is significantly obstructed, then all the venous flow will be obstructed. Cor triatriatum usually happens in the left side. Occasionally, a cor triatriatum, which means we have a heart, a core, with 3 atria, 1, 2, 3. It can happen also on the right side and cause cor triatriatum dextrum. So it depends on the obstruction. The usual presentation of cor triatriatum is early in life, and the usual effect is usually severe. So cor triatriatum is usually a severe stenosis. significant stenosis. It is usually moderate to severe or severe, but nothing less than that. If we know that core triatriatum is usually moderate to severe or severe, then now let's talk, as we said before, about what? About pressure gradients. If we said like before, this is the mean left atrium of 8 millimeter mercury, okay? And we know that if we talk about severe stenosis, then we usually have pressure difference, anything between 12 and above, usually 12 to 18. We can take the middle part, which is around 15 millimeter mercury. So 15 plus 8. Then the pressure here will be what? Will be 23 millimeter mercury. And similarly, all these veins, the 4 veins, will have the same pressure. And going back to the lung, if we go back to the lung, then the left or right pulmonary artery, both of them pressures will be elevated. The normal mean pulmonary artery pressure, we said is between 12 to 18 again. If we add 18 plus, this is now 23, this is 8, the difference is 15. So if we add the difference, which is 15, to a normal pulmonary artery pressure, which is 18, that will give us a mean pulmonary artery pressure of around 33 millimeter mercury. This is the mean. If we push or give a higher systolic pressure, this is the mean. The systolic pressure is probably plus another 20, maybe another 30. Let's take a 25. So 25 plus 33. The PA pressure here will be 25 plus 33. What is it? Will be 58 millimeter mercury, obviously significantly elevated from the normal pulmonary artery pressure, which is around maximally 24. That's almost 2 times plus the normal PA pressure. And whenever we know that any pressure that elevates more than 2 times, 2.5, 3 times, it is usually a significant elevation. What would be the right ventricular pressure? I'm taking you the way I think, and I want you to follow that so you can figure out what problems we can have. So a systolic pressure of 58 in the main pulmonary artery, we know that the right ventricular end diastolic pressure maximum, let's say 8 plus 58, that will be a 66 millimeter mercury right ventricular systolic pressure. Again, significantly elevated. How can we tell about significant elevation or not? In a child, a usual systemic arterial pressure will be anything between 100 to 120 systolic blood pressure. If your right ventricle exceeds half of it, then this elevation is quite significant. More than 50% of the systemic elevation in the RV systolic pressure is quite significant. And once we reach severe and significant, we can start expecting the effects or the pathophysiological effects. So if it is moderate to severe, it's like moderate to severe pulmonary venous stenosis. We will have moderate elevation of intraparenchymal pulmonary venous pressure, maybe slight extravasation of the extravascular fluid to the of the intravascular fluid to the extravascular compartment, causing mild to moderate pulmonary venous edema, causing mild to moderate pulmonary arteriolar pressure elevation, causing moderate right ventricular RV pressure. This is severe. We're talking about now just if the obstruction was moderate. Moderate RV pressure increase. It can give us mild right ventricular hypertrophy. Usually RV function will be maintained quite good unless this moderate obstruction or moderate to severe remains for a long time. Pulmonary valve regurgitation will be mild, maybe moderate, usually mild. Tricuspid valve regurgitation will not probably exceed mild regurgitation. Cardiac output from the right side to the lung will be maintained. Cardiac output from the venous side through the moderate to severe obstruction cord, right atrium to the left side will be maintained, and the systemic blood pressure will be maintained. Not much decrease in systolic function, maybe some elevation of the right ventricular and diastolic pressure. The tricuspid valve regurgitation will not exceed moderate by all means, probably mostly mild, and we will not have significant elevation of the right atrial pressure, nor we would have venous stagnation on the right side. Once the stenosis becomes severe and we reach these numbers and we reach more than 50% systemic elevation of the right ventricle systolic pressure, we start seeing the effects. We start seeing the pulmonary venous edema, the elevation of the pulmonary arteriolar pressure with all its complication. And again, I say this is an obstruction caused pulmonary hypertension. So the permanent effect or the long-term effect are much slower in happening than in primary pulmonary hypertension. Pulmonary venous edema happens significantly with such obstruction. Decreased cardiac output can be expected with severe cardiac cord triatriatum severe stenosis because of two things. The limited amount of blood going to the left side, it rarely goes to hypotension, but it can happen if the obstruction is more than severe, if it's critical obstruction, really limiting the fluid to less than the basic minimal that's needed to maintain the cardiac output. The right side cardiac output will be hindered in severe stenosis because of severe elevation or significant elevation of pulmonary pressure, especially if it was associated with right ventricular systolic or diastolic or both dysfunction plus the tricuspid valve regurgitation. So severe obstruction to the pulmonary venous flow in cord triatriatum on the left side can mimic severe pulmonary vein stenosis. And obviously, such patients will need removal of this membrane and letting the flow just normalize, and all this pathophysiology should reverse back to normal, including the pulmonary artery pressure, with not much permanent effect on the lung function nor on the pulmonary arteriolar structure. So from this, I'll just move to the next part, which is again, do we expect arrhythmias in such patients? Unless RV failure and severe congestion on the right side, usually arrhythmias are not associated in such patients. If we take it now to the next area that could be obstructed in such congenital heart disease of the obstructive lesions of the left side, the same membrane may actually be just above the pulmonary, the mitral valve with just a tiny hole here. So here we have a very spacious area of the left atrium. Flow can come easily. The obstruction here, if it is mild, and when we say mild, this is what we call, let me just take away the names because they are different now. Supra, number 3, supra mitral ring or obstruction. Mild, talking about a mean gradient between the left atrium and the receiving chamber, the end diastolic of the left ventricle, less than 5 millimeter mercury. Again, I'll leave you to answer this. Would you expect any symptomatology, any significant pathophysiology? No, because again, the flow will just go easy. The congestion in the veins will not be much. The congestion in the lung would not be much. The elevation of the pulmonary artery pressure will not be much. The right ventricular function and pressure should be maintained. The tricuspid function should be maintained. The right atrium should not have a significantly elevated pressure nor venous congestion. The cardiac output will be maintained from the right side to the left side and from the left side to the body. The sizes of the atria and the ventricles will almost be normal. This is mild. In moderate, supramitral ring obstruction, gradients of less than 12, but up to 12, less than or 11 millimeter mercury. Then here we start seeing the effect of moderate elevation of left atrial pressure, because now we have the left atrium as a whole. The pressure here, which we said it was before 8 millimeter mercury, if we add the, let's say, if we said moderate is up to 12, let's say we will add 10, then the pressure here will be around 18 because of this supramitral stenosis. If the pressure here is 18 and we know the mean in the lung is another 18, so it will be around it will be around 20, it will be elevated to around 30 or 28. And if we add the 20 of the normal systolic pressure, then we would expect the RV systolic pressure to be around 50, almost 50% systemic or slightly less. And in this stage, we will still maintain the cardiac output. There will be left atrial enlargement, moderate left atrial enlargement. The left atrium will have to enlarge to accommodate the higher pressure and the volume that is somewhat stagnating in it, delayed emptying into the left ventricle because of the moderate stenosis. There will be mild distension and dilatation of the pulmonary veins, and possibly mild pulmonary venous edema that may not necessarily will show on a chest X-ray. And there will be at least mild to moderate, maybe moderate elevation of the pulmonary artery pressure, anything between 28 to 30 millimeter mercury, causing at least moderate RV systolic pressure, causing right ventricular hypertrophy, mild to moderate, still able to push the cardiac output. The end diastolic pressure in the right ventricle probably will not get affected. The pulmonary regurg will be mild at maximum. Pulmonary arteriolar pressure complications will be, or pathophysiological effect will be very minimal, because the mean pressure is only moderately elevated, no much right atrial enlargement or elevation of pressure or venous obstruction, cardiac output on the left side will be still maintained with a maintained blood pressure in such moderate obstruction. If it goes to severe obstruction, then you see now it's easier for me to talk because I've taken my time in the pulmonary venous obstruction part, talking in more detail. If we go, and now this is a severe obstruction, the supramitral ring, which means we have, if it's severe, we have a gradient, a mean gradient of more than 12 millimeter mercury. Then obviously we have a severe obstruction. There will be pathophysiological effect on the structure. There will be significant left atrial dilatation with all its effects, including clot formation, that's possible, especially in the left atrial appendage, including atrial arrhythmia, mainly atrial flutter, but can be atrial flutter or fibrillation or other supraventricular tachycardias, even to the extent of sometimes a degree of complete heart block. Obviously, we will have significant pulmonary vein dilatation and enlargement with significant pulmonary venous development because of the extravasation of the intravascular fluid to the extravascular compartment, causing pulmonary venous edema, significant elevation of the mean PA pressure to around 40. And obviously, if this is the mean in the pulmonary artery, then our mean systolic RV pressure would most likely be around 70 millimeter mercury. And here we are again with significant right ventricular systolic pressure elevation, quite significant, in the ranges of 70 or more. And we will get the effect of that on the right ventricle: hypertrophy, loss of function, increase in diastolic pressure, dilatation, tricuspid valve regurgitation with different degrees that would actually complicate the matter and make it quite worse, with loss of efficient cardiac output from the right side to the left, and also loss of efficient cardiac output from the left side to the body, including a smallish left ventricle, possibility of aortic stenosis or coarctation, and when it is critical, it can even present in cardiogenic shock with all its pathophysiology because of the severely limited cardiac output. By this, we finished the third obstructive lesion in congenital heart diseases. We talked about the pulmonary vein stenosis, the cord triatriatum, and the supramitral ring. I will finish my session today by talking about the mitral valve stenosis and take it from there. طيب بسم الله الرحمن الرحيم صلى الله وسلم على نبينا محمد وعلى آله وصحبه أجمعين. So continuing on the same theme, pathophysiological effect of congenital heart disease, pathophysiology of left-sided obstruction. Our number 4 lesion is mitral valve stenosis. Mitral valve stenosis. Again, mild, moderate, severe. This is the heart again. tricuspid valve, and this is the area we are interested in, the mitral valve. Mitral valve stenosis can happen, as we talked just a while ago, supramitral or at the mitral valve leaflet or within the mitral apparatus, the papillary muscles, which give the chordae that hold the mitral valve. So anything from here to there is mitral valve stenosis. It can be the whole thing, just obliterated, amalgamated, or single papillary muscle like we see in Schwann complex, or abnormal chordae, whether short or melted together, or abnormal leaflets with severe stenosis and stenosis of the annulus of the mitral valve. So regardless of where it is, we will also treat it as, and regardless of the cause, the congenital cause, or congenital association in such mitral stenosis, we are going to talk about the pathophysiological effect. If it is mild mitral valve stenosis, again, a mean gradient here, we accept not the 5s that we accepted before in the atria, because that was really more of the venous channels, if you want, the left-sided venous channels, if you want to call it. Here, anything between mean of 5, probably up to 7 millimeter mercury is considered mild mitral valve stenosis. If the left atrium pressure is, let's say 6, 8, let's take the 8 plus the 7, in mild mitral valve stenosis, the left atrial pressure will be what? Will be around 7 plus the 8 will be around 15. And this is the mitral mild stenosis. Would we expect, if the left atrial pressure is 15, much effect? Yes, we would expect some effect. But again, if this is 15, then the pulmonary veins pressure will also reflect a 15. And if we know, and we have said before, the pulmonary artery pressure mean of, let's say, 12 to 18, we can take the 12 as the mean plus a mean atrial pressure of 15, then we are going to get a PA pressure, a mean PA pressure of 27. If we add the 15 to 20 of the RV pressure, then your RV pressure with a mild elevation, an almost mild to moderate, because I've taken the higher number. Say if I take the 5 plus 8, that's 13 plus 12, it will be 25 plus 20, I'll get a 45. So a 45, we agreed, it's less than 50% systemic of a usual child or an infant who's more than 3 months old systemic pressure. That will be just a mild elevation in the right ventricular systolic pressure to around, let's say, 45 millimeter mercury. This again, if it is only mild mitral valve stenosis, what are we expect? I think you are now experts in such a thing. We will follow what would happen pathophysiologically. This obstruction now, will it limit the cardiac output if it is mild? The answer is obviously no. The cardiac output will be maintained completely. Blood pressure will be maintained. Cardiac output, whether right side to the lung or left side to the body, will be always maintained in mild mitral valve stenosis. Okay, if it doesn't affect the cardiac output, will it affect the left ventricle, whether hypertrophy, dilatation, or being smaller size? Obviously, no hypertrophy, no dilatation is actually taking away some volume from it. So it should not hypertrophy, it should not dilate. Would it limit the size of the left ventricle? No, it would not limit the size, because still the cardiac output can pass, although on the expense of elevation of the left atrial pressure. Normal left end-diastolic pressure of the left ventricle, maybe it will be on the lower normal side, nothing of any significance in a from a pathophysiological point. So if this is what was on the after effect, what would be on the pre-effect before the stenosis? Would we see any significant left atrial dilatation with mild mitral stenosis? It's very unlikely. So that pathophysiological effect is usually not there, not much elevation. Will we see significant stagnation of the blood in the left atrium to the extent it may cause clotting and thrombic formation? Obviously, the answer is no. So the left atrium will be fine because it's not dilated. Do we expect any atrial arrhythmias in such patients? Usually we do not expect. Most of the time there will be no atrial arrhythmias because of just a mild mitral stenosis. Going in now to the pulmonary veins, would we expect any significant dilatation of the pulmonary veins? Maybe mild dilatation. Do we expect pulmonary edema, venous edema, because of the extravasation from intravascular to extravascular compartment? No, we do not expect that. We do not expect pulmonary edema. We do not expect significant rise in the PA pressure. It will be just a mild, maybe a mild plus rise in the mean PA pressure, which is quite tolerable, with no significant effect on the pulmonary arteriolar bed, not acute, nor chronic, nor permanent, with not much effect on the right ventricle, except maybe right ventricular hypertrophy mild if it is continued for a long time. We do not expect any significant pulmonary valve regurgitation with no effect of it, obviously. We do not expect any tricuspid valve regurgitation in such patient, and no venous pressure elevation in the right atrium, nor in the superior vena cava or the inferior vena cava. Obviously, mild mitral stenosis is really acting like mild pulmonary vein stenosis, like mild supramitral or a mild core triatriatum. I didn't mention in the core triatriatum that there are some cases where actually it is not moderate to severe or severe. It's just mild obstruction, and these cases will act like mitral mild stenosis or pulmonary veins mild stenosis. Okay, so if this is mild mitral valve stenosis, any other effects? Or in congenital mitral stenosis, any other things we should be looking at from pathophysiological? Yes, if it was associated with other left-sided obstruction. The more we come to the mitral valve, the aortic valve, the coarc, the more the association becomes apparent, especially in shunt complex. You may have mild stenosis with moderate aortic valve stenosis with a mild or moderate coarctation of the aorta. One important thing in mild mitral stenosis, when we evaluate it by echocardiography especially, we have to make sure that we do not have any change or any significant change in the left ventricular end diastolic pressure because of the associated lesions. Sometimes if we have moderate to severe aortic stenosis, the EDP or the left ventricular end diastolic pressure here will be high. And because of that, the mean gradient, which is the difference between the left atrial pressure, the pre-obstruction pressure, and the post-obstruction pressure, which is the left end diastolic pressure, left ventricular diastolic pressure, we will have a less mean. And by numbers, it will fall in the mild area. But then it is not mild because it is falsely mild because this pressure is elevated. Okay, so the caveat in evaluating mild mitral valve stenosis is that we have to make sure the left end diastolic pressure in the left ventricle is not elevated and falsely giving us a lower number, because if we have significant aortic stenosis, coarctation, aortic regurg, subaortic stenosis, then the pressure here during diastole will be higher and hence the gradient will be lower, and yet the left atrial pressure will actually remain high. It's just that we are falsely measuring because we are only calculating, minusing left atrial from EDP and getting a number. So numbers don't mean much when there is associations with other lesions. When there is association, your pathophysiology may be quite different, and we'll have to figure out which is the most important lesion, and that most important lesion will give you the most important significant pathophysiology. So if we just finish talking about mild mitral valve stenosis, let's talk about moderate. What is the mean gradient where we call it moderate? The mean gradient would be anything between 7 to around 12 or maybe just 10, let's say 7 to 12 millimeter mercury mean gradient. That is a difference between the left atrium and the end diastolic left ventricular pressure. Now the mitral is more stenotic, as you could see. If we said that the left atrial pressure was 8 in a normal person plus 12, then now the pressure in the left atrium is 20 millimeter mercury, and obviously in the veins it will also be another 20, and in the pulmonary artery, if now the difference, let's say, is 12, and we know that we had a mean PA pressure normal between 10 to 18, add that 12 to the 18, we said it was about 25 to 27 in the mild. Now we will have a PA pressure of around 30 mean millimeter mercury. If we add the 20 millimeter mercury to give the systolic, or 25, whatever you choose, it will be around 50 to 60 millimeter mercury. So we would expect now at least moderate elevation of the right ventricular systolic pressure, anything between 45 to 60 millimeter mercury. 45 to 60 millimeter mercury. And here we do have moderate elevation of the right ventricular systolic pressure. If we know that, then we can actually figure out the pathophysiological effect. Let's start from the mitral, and just after it, would that affect the cardiac output, moderate mitral valve stenosis? No, the cardiac output will be maintained. Would that affect the EDP? No, but it could be on the lower normal. Would that affect the cavity size? Possibly. Mild decrease in left ventricular end-diastolic volume, but not significant. And that would be it. Would it cause any effect on the other after structures, like on the aortic valve or the aortic arch? Usually not. It's only moderate, unless it's an association from the start. Would it cause any decreased cardiac output or left pressure or any organ ischemia because of limitation of cardiac output? No, because there is no limitation of cardiac output, and the pressure is actually still maintained. If we go on the area above, we will have now mild to moderate left atrial enlargement, because the pressure now, the mean is 20, with possibility of atrial arrhythmia if it was left for a long time. That means at least months to years, not weeks, not days. Plus, would this give us stagnation of the blood in the left atrium to the extent that we might expect thrombus or clot formation? No, unless chronic atrial arrhythmia, especially atrial flutter fibrillation, is there, then clots can form in the left atrium with its all pathophysiological complications. We will have moderate elevation of the pressure in the pulmonary veins. This will give us at least mild, maybe mild to moderate. Actually, it will not give us moderate. It is just going to give us mild pulmonary venous congestion apparent on the X-ray, and it's usually bilateral. The pulmonary pressure will be moderately elevated, not much permanent or acute or chronic effect on the pulmonary arteriolar bed, unless again it was left for a very long time, because it's still pulmonary hypertension, although it hasn't reached severe pulmonary hypertension. The right ventricular pressure, because it's moderately elevated, we will have right ventricular mild to moderate hypertrophy. The systolic function of the right ventricle is usually maintained. The diastolic function of the right ventricle is usually maintained, unless in extremely long periods where it is left for a long time, they might show affection, but the usual rule in moderate mitral stenosis is that the right side, although moderately elevated pressure, will maintain good function and good diastolic filling pressures. Pulmonary valve regurg, probably trivial to mild, not much effect on the pulmonary valve. Tricuspid valve regurgitation may be mild, may reach up to moderate depending on the right ventricular hypertrophy that happens and the function, which is usually quite maintained. So tricuspid regurg, again, here is not a major player in the pathophysiology of moderate mitral valve stenosis, nor would we expect higher pressure in the right atrium, nor in the venous system, and no venous stagnation. And as I said, the cardiac output would be quite maintained. If we go to severe mitral valve stenosis, then the story is different, and I'm sure you already can figure out from what I have just said for the other examples and the other diseases, you can figure out what to expect. So here we expect a mean of above 12 millimeter mercury to call this mitral stenosis quite severe. So when it's quite severe, then there is significant limitation of right-sided cardiac output through the pulmonary veins to the left atrium to reach the left ventricle. So let's talk about, as we said, what would we expect on the left ventricle? End-diastolic volume will be decreased? Possibly, yes. Size, obviously, possibly, yes, decreased. It can range from normal to severely hypoplastic. There's no real guessing or explanation of why does it go from mild, moderate, or severe hypoplasia of the right ventricle or just normal. But in general, the end-diastolic volume of the left ventricle is decreased in severe mitral valve stenosis. Is the cardiac output maintained? Yes, unless it becomes critical. And why is the cardiac output maintained? Because of so many other regulatory mechanisms that actually maintains the cardiac output, whether it's the elevation of the RV pressure, the hypertrophy, elevation of the pulmonary artery pressure to keep pushing the blood through the stenosis of the mitral valve, and the systemic vascular resistance, which can increase because of it is seeing low cardiac output. It will just tend to vasoconstrict, especially the areas where the blood flow is not needed, like your splanchnic area, and then the blood pressure will be maintained, plus your fight and flight hormone changes that can maintain your cardiac output, given though it is still in the severe area. If mitral stenosis become critical, then we start seeing the low cardiac output state with all its complications of decreased cardiac output, low blood pressure, peripheral and organ low perfusion, ischemia symptoms, and so on. But this is quite a distressed type of condition. So that's the effect of after. So what is the effect of before the severe or critical mitral valve stenosis? We will see significant left atrial dilatation. Sometimes we call it ballooned left atrium. It's huge. It almost is the size of half of the heart or 2/3 of the heart. That's quite a dilated left atrium. So we expect all the complications and the pathophysiology that comes from a dilated atrium. Two major ones. Atrial arrhythmias is quite common in the severe mitral stenosis group, especially if there is a long-term severe stenosis, so atrial flutter, fibrillation, other atrial arrhythmias, variable degrees of heart block, left atrial thrombus formation, especially in the left atrial appendage, especially if it was associated with the arrhythmia, then yes, we would get that effect. We will have significant pulmonary vein enlargement and dilatation with elevation of pressure. So if it is here 12 and if it is above 12, let's say 12 to 18, and if we take the 18 plus the previous 8 of the normal left atrium, then this pressure will be 26. Your pulmonary artery pressure, if the gradient is 18, the difference is 18 plus the normal 18, our mean PAP will be in the range of 35 to 45 millimeter mercury. Now we're heading into the severe area, because if we just add the 20 millimeter mercury to give a systolic pressure, we will have an RV systolic pressure of much more than 55 to 60. At least we will have an RV systolic pressure of around 65 to 75 millimeter mercury. So if this is the situation, I'm sure you now can figure out what's going to happen. We've reached the pulmonary veins. It's quite dilated. The basement membrane pores are now quite stretched. The intravascular fluid proteins will now extravasate into the interstitium of the lung, causing pulmonary interstitial venous edema. The pressure in the venules is extremely high. It will cause reflex bilateral pulmonary arteriolar vasoconstriction, leading to the severe pulmonary artery pressure elevation. Pulmonary artery pressure complications is part of the pathophysiology of severe to critical mitral valve stenosis. It may give you long-term effects in terms of permanent, chronic on the pulmonary arteriolar bed if left untreated for a long time. Usually it's much less aggressive than primary pulmonary hypertension, but again, it is severe pulmonary artery pressure with all the package that comes with it. The pulmonary arteries will also, the main pulmonary arteries will be significantly dilated and their walls will be thickened. The muscular part of the pulmonary artery wall will be quite significantly hypertrophied, and the fibrous part will quite be thickened and stiff. We may have, or we will have, when we have severe pulmonary pressure elevation, we will have significant mild, maybe mild to moderate pulmonary regurgitation, although it will not be a major player in the whole pathophysiological effect. The right ventricle will significantly hypertrophy. It may dilate, it may lose systolic function. The left ventricular, the right ventricular end-diastolic pressure will elevate, and then we will have varying degrees of tricuspid valve regurgitation depending on how much annular dilatation because of right ventricular dilatation and hypertrophy. We may have mild, moderate to severe, and hence we do expect an elevation of the right-sided venous pressures, the right atrial pressure, the superior vena cava and the inferior vena cava, with all the effect on other venous systems, whether they are upper body and brain, or it is lower body, the liver and the splanchnic area, with all the pathophysiological effect of elevation of a venous pressure systemic. All of that can give us significant pathophysiological effect. So you see, severe mitral stenosis, and especially if it was more towards critical, has a very bad effect on all the components. Left-sided cardiac output, left-sided ventricle, left atrium, the pulmonary veins, the pulmonary artery, pressure and structure, the pulmonary valve regurg, the right ventricular loss of function, elevation of pressure, loss of function, hypertrophy, dilatation if left, and dysfunction if left for a long time, tricuspid valve regurgitation as a complication, pathophysiological finding because of severe or critical mitral stenosis, and right-sided congestion with all its back effect on the body, and even right-sided venous thrombus formation in the worst situation. By this, I hope I have covered up to mitral valve stenosis pathophysiology. In the next sessions, inshallah, I will cover the aortic valve stenosis, coarctation of the aorta, to end up the pathophysiology of left-sided obstructive lesions. And from there, inshallah, we will move into regurgitant lesions, pathophysiology. Hopefully, I can also do the pathophysiology of acquired heart disease in children, especially rheumatic heart disease and Kawasaki. Thank you so much.